Radiology, Alexandria University, and she is one of the really the pioneers in women imaging in Alexandria and in Egypt. She will be talking on the multiparametric breast MRI for evaluation of response to neoadjuvant chemotherapy. Professor HEBA, the floor is yours.
Good evening, everybody. I hope you're enjoying yourself like I am, not only for the fruitful lecture, but also in the sea view and sunny weather. So today, I think the screen is not working. Okay, so I think this is the aim of each and everyone working in the MDT team, to put a smile on our patient's face. And in order to do this, there's a trend nowadays, ever since the 90s, to opt for breast conserving management plans. And in order to do this, there is nowadays the need for neoadjuvant therapy before any surgical intervention. And even some patients who have a vanishing tumor might just continue by breast conservative management without even the surgery. And in order to identify responders from non-responders as early as possible, we have to monitor our patients. And today we're going to talk about the MRI. Yes, we do mammogram and ultrasound, but why should we do MRI? But before we ask ourselves this question, I just want to foster and focus on a very important topic, which is this one here. We have an MRI of the breast after therapy. Can you identify any lesions? Well, we might have a very small focus, but is this the main lesion? Well, we have to do a baseline MRI before the start of the treatment, even not after the first or the second cycle occurs. Even then, the tumor itself would have changed. The next thing is we have to localize our cases, again, before the start of the treatment. Don't wait after the first or second cycle. And as you can see here, in cases of vanishing tumors, you still can identify the site by the clip, which can again be very marvelously identified by the artifact produced on the MRI. Or else, if you are dealing with a vanishing tumor with no localization, you're going to have to do a mastectomy, unfortunately. So why MRI? According to the ACR appropriateness criteria published in 2017, and it's been revised up to 2022, in the initial detection of the tumor, both the mammogram, ultrasound, as well as the MRI go nose to nose. But if you look after the initial or even completion of therapy, you would find that MRI actually has a higher head. Still, be sure that if you are dealing with axillary lesions or lymph nodes, ultrasound is still the king, whether in the initial or in the post-management, okay? And according to the NCCN guidelines, which is considered more or less like the Bible for our dear clinicians, they again opt for MRI before the start of the treatment. Up till now, we use what we call the RECIST criteria in order to monitor our cases. The RECIST criteria depend mainly on the anatomy, and this means we're going to measure the longest dimension of our lesion. Unfortunately, up till now, we don't have any established functional system, but for the PET-CT, the persist, okay? Not for the MRI. However, the RECIST 1.1 did say that the best imaging modality we should use in cases of breast cancer should be the MRI. As you can see here, yes, we can identify what we call partial pathological or radiological, in this case, response by the decrease of the longest diameter of the lesion by more than 30% on the mammogram and the ultrasound. And if you have no tumor left, this is going to be called a radiological complete response. However, everything is not that clear, and we have many gray zones, like in this case here, where we have a lesion who underwent therapy. However, on the mammogram, you would find that the lesion looks more or less stable, did not change in size. However, after removal, it did prove to be a complete pathological response. So this was actually just necrotic tissue. And this cannot be identified only on the mammogram and ultrasound. And hence, we go for the behavioral monitoring by MRI. In MRI, we have, in addition to the conventional morphological T1 and T2 sequences, we have what we call the contrast and non-contrast based behavioral sequences. And we're going to talk about them by examples better. If you look at the contrast, we would start by the very easy curve pattern. We know that more or less most of the malignant lesions present with a type 3 curve pattern. So if your patient is responding to treatment, the vascularity of the lesion would decrease, and this curve pattern might even change after even the first or second cycle of chemotherapy, as you can see that it shifted to a type 1 curve pattern. You might have what we call the complete radiological response, meaning that all lesions that you see before treatment already vanish after treatment. Or you have what we call the partial response, but this one can be either in what we call concentric or non-concentric fashion. Concentric meaning that we have a lesion totally confined without any enhancing foci, it shrinks in size. While in the non-concentric, it's usually more or less with multicentric lesions or non-mass lesions, where you would have mottled, or we call it sometimes crumbled or fragmented active tumor foci within a necrotic bed. But still on surgery, the clinician has to remove the whole area. Okay? The other thing that we have to ask ourselves is, okay, we have a lesion that totally vanished on imaging, but are we sure 100% that this radiological complete response would correlate with the pathological complete response or not? And this is very crucial. You have to know that MRI sometimes either over or underestimates the results. Overestimation is not that problematic because the clinician is going to remove the tumor anyway. The problem is with the underestimation, especially in cases who would say, okay, I don't want any surgery, I'm just gonna go for follow-up. So you have to know that it more or less depends on the molecular subtype of the disease, and you have to communicate this very well with your clinician, and hence the MDT decision for your cases. So, patients who have either triple negative or HER2 enriched disease, once you see a complete pathological, radiological response on MRI, this correlates well with the pathology. However, if you have patients with hormone positive disease, this means that you might have what we call a radiological complete response, but does not have to correlate well with the pathology. The other thing that we sometimes look at the early and the late phases. If you have an enhancement within the early phase, this means that you still have a tumor active. If it's only in the late phase, this usually might be due to the treatment inflammatory changes. Again, pathological complete response means that I don't have any invasive disease, and in order to see this invasive disease, this is usually seen in the early phase. DCIS is not considered as a part or crucial part, but still you have to give your clinician the whole extent of the lesion that he was going to go in and remove, and hence you have to give him the whole topography on the delayed phase. So let's look up some examples. As you can see here in the upper image, this is an invasive hormone positive disease. After treatment, both in the early and the delayed phase, we have a very small focus. We're going to measure it and say that it's a partial, of course, response. We still have some tumor. However, the pathology report came in with a larger tumor size than on the MRI. This is accepted because you know that you are dealing with a hormone positive disease. On the other hand, this very well defined mass here, triple negative. On the early phase, you just have very two small foci that persisted on the delayed. When measuring this and referring it to your clinician, it's correlated well with the pathology because it's a triple negative. This case here was HER2 enriched. On the early phase, there was no enhancement whatsoever. On the delayed, there were small enhancement foci, but because it was only on the delayed, we lean more towards it being just post therapy changes. However, we have to communicate well and still say that we do have some residual. But again, the pathology proved that yes, this was just merely post-management changes, and there was complete pathological response. This is another example that we have to be very careful about. As my dear Professor Dr. Naveen said, once you have a lesion, you have to biopsy it before surgery, because as we see here, we have 2 lesions. One of them vanished completely, the other persisted. So with this, the other lesion, again, a benign or a malignant disease, pre-surgically it was biopsied and it was proven to be benign, and after removal and surgery, it was still benign. And this is how, again, MRI might overestimate a disease if it's actually a coincidental benign finding. Another thing that is very crucial for you to know is the type of management that your patient is receiving. If she's receiving one of the taxanes family, this means that you are anticipating what we call an anti-angiogenic effect, meaning that this therapy would decrease the tumor vascularity even if I have a residual tumor. As in this case here, this is a very well-defined mass, triple negative. So we usually say if I have a triple negative disease with no enhancement, this should be just necrotic tissue. However, this patient was receiving taxanes. And if you look carefully, you will find that even the background enhancement of the whole breast decreased, because as an overall example. So, know the tumor subtype. Molecularly, you have to identify or know the treatment type also. Now going for the diffusion and spectroscopy, they made life a little bit easier. Unfortunately, they are still not part of the buyer's lexicon. Hopefully they would be. At least diffusion, because it's now a routine within integral part of the routine studies. It's very easy. If you have cellularity, viable, you're gonna have restriction and low ADC. If you have necrotic tissue, it's not gonna be restricted. As in the tumor here, we have just rim enhancement and there is necrotic tissue within. After therapy, there might be a little bit of delayed enhancement, but there still was no diffusion whatsoever, and this was total complete pathological response. And we've actually done some research about the diffusion use as early as the first and second cycle to identify responders from non-responders as early as possible. As you can see in this case here, sizable infiltrative mass, diffusion restricted with very low ADC value. After the first cycle, there was no change in the size, of course. The ADC, it increased a little bit, but not more than 25%, and this made us anticipate that this tumor is actually a non-responder. And yes, at the end, there was still significant residual. While on the other hand, this case here, very sizable, very huge, very diffusion restriction, low ADC. After the first cycle, we had an increase in the ADC value more than 25%, and this made us anticipate that it's going to be a responder. And actually, at the end of the treatment, yes, we have a crumbled small size, still a residual, but because there is no diffusion restriction, on pathology, they came back that there was merely just very few fragmented foci, and most of what you see here is just reactive, post-reactive, or necrotic tissue. On the choline, for spectroscopy, in spectroscopy, we only identify choline. If you have high choline curve, meaning you have high cellular turnover, malignancy, if it's low, you've got necrotic tissue. And usually, again, choline, the same as in diffusion, changes precedes the size. That's why you can see that the curve is decreasing even before the size decreases. And that's why you have to look very carefully for the choline curve, because if it increases even after therapy, and the size is still decreased, you would anticipate that it would increase again, and this was a non-responder. And again, we did some research in this field as early as the first and second cycle. And as you can see here, we've got a case giving you a type 3 curve, marked diffusion restriction, and a high choline curve reaching up to 11 arbitrary unit. After the first cycle, the curve changed, the diffusion ADC value increased, and there was a decrease in the choline. And at the end of her cycle, I don't have any images for you to show because it was a totally vanishing tumor. So is this it? Well, there is, of course, the AI nowadays and the radiomics and the deep learning of the machines. And as you already know that they are feeding the machines with lots of data according to the morphology, the enhancement pattern, diffusion, spectroscopy, in addition to the clinical, molecular, and subtyping and types of treatments, so that they are trying to, nowadays, to aim to look at the baseline MRI and just give you a clue if it's going to be a responder or non-responder from the start. So, though it's still not standardized, but it's showing promising results. So in the end, whenever you have a case undergoing neoadjuvant therapy, use MRI, not just the conventional mammo ultrasound. Yes, you can start with it, but better yet, do MRI and do the baseline before the start of the treatment. Know that the tumor molecular subtype matters. If it's triple negative, HER2 enriched, you're good to go. But be careful of the hormone positives. And of course, cases might be associated with DCIS, as well as the treatment itself. If your patient is taking taxanes, look very carefully. Up till now, there is no standardized guidelines for us how to follow up such cases on the virus lexicon, but we are all anticipating the 2023 changes, and I hope, this is it, I already finished, by the way. I already finished, okay? I just want to, looking forward to see you next year and many years to come. And thank you.
Thank you, dear Professor HEBA HASSAN, for